Assalamu alaikum everyone once again, and a very good evening to all of you. My name is Eeman Ahmad, and I'm a third-year medical student here at the FMH College of Medicine and Dentistry. I'm also one of the core team members at the Center for Health Sciences Research, which is a research platform at FMH. It is a collaboration between the current students of FMH as well as the alumni of FMH to encourage research among the students of FMH. So today, we have the first journal club session of the year. We've had 2 journal club sessions in the past, and this is the third journal club session of CHSR. In this journal club session, we will be discussing one of the biggest studies, one of the biggest surveys that was done in Pakistan. It is the Diabetes Prevalence Survey, which basically had 18,000 participants. And as we would explore the study further, we'll see why it is so important to discuss this study, right? And the importance, as the aim of conducting journal club sessions is to basically discuss topics that are of importance. For example, since we're living in Pakistan, topics that are important in Pakistan. So diabetes is one of the major, it is the most common chronic disease worldwide and is very important in Pakistan, very important to explore in Pakistan as well. So without further ado, I will be starting with the presentation first. And after I am done presenting the paper, we will be joined by Dr. Hamayle Saeed, who is an alumni of FMH. And after she graduated from FMH, she is currently working as a postdoctoral research fellow at the Johnson Diabetes Center, which is the biggest diabetes research center in the entire world. It is affiliated with the Harvard Medical School, and we are thankful to her for taking out the time to join us here today. So without further ado, let's begin. All right. So a few points about the article. It is a Pakistan-wide community-based survey. So there are a lot of diabetes prevalence surveys that have been done in Pakistan that were not done across the country, right? So this particular survey looks at data, looks at participants from all over Pakistan. Essentially, we're looking at the prevalence of type 2 diabetes, and this particular study uses HbA1c as a screening test, right? This article that was also shared with you in your emails was published in the BMJ Open, which is a pretty good journal, and it had over 18,000 subjects. So it had 18,856 subjects, which makes it the largest study to date from Pakistan, right? So not just the largest, study on diabetes, it is the largest study from Pakistan. So why did we choose to discuss this particular survey? One of the strengths of the study is that it is the largest ever national prevalence study of type 2 diabetes, right? That makes it an obvious choice to discuss here today. But also, diabetes, Pakistan is the third highest ranking adult population with diabetes. So we have our adult population, out of our adult population, 13.8% people have diabetes, right? And this was published by the IDF. You should look into it more if you're interested in diabetes. Actually, all of you should look into it more because all of us should be interested in diabetes. And the second reason is that because diabetes can be managed easily. So we have a lot of management options, treatment options, and because it is so easy to manage, so it should be diagnosed timely. And we should understand the risk factors that are associated with diabetes, as we will see in the survey. And once we understand those risk factors, that makes it much easier for us to, diagnose diabetes in patients that we see in the future. Okay, so I took a snapshot of the authors as well as their affiliations. As you can see that this particular survey had authors from all over Pakistan. So from Peshawar, from Karachi, from Multan, Islamabad, and also 2 authors from who were affiliated with universities in the UK. So they did have technical assistance from the UK. Okay, so coming to the article, so they've discussed these important points in their introduction. Type 2 diabetes is one of the most common public health issues worldwide. And usually diabetes we used to see diabetes in developed countries more, but because there has been a change in nutrition, People are becoming lazier. Their their lifestyles have changed, right? So that is one of the major reasons why we're seeing diabetes so much more in middle income and low income countries as well, right? And before 2018, there was only one national diabetes survey that was published in 2007, which was a long time ago, right? And they used the oral glucose tolerance test, whereas this survey is using HbA1c. They calculated the prevalence to be 11%, right? And the IDF Atlas, the fifth edition of the IDF Atlas reported it to be 6.8%. However, healthcare professionals, doctors, clinicians do comment that these prevalence, these percentages are much lower than what they expected to be in reality, right? So they see a lot more patients than would be expected if the prevalence was actually 11% or 6.8%. Moving on, there were a few surveys done, but there are conflicting findings from these surveys. 7.2% till 19.21%, that is the range that we've seen of the prevalence percentages. So that is a wide range, right? That is why it was essential to conduct such a national survey to see what the actual prevalence is, right? So the American Diabetes Association, they've set this criteria that you should check either the fasting plasma glucose or the OGTT, which is the oral glucose tolerance test, to diagnose diabetes, right? But OGTT is time consuming, requires fasting, and it is not always reproducible, right? So for that reason, in this survey, we've used HbA1c. Okay, so as we've already mentioned, they've used HbA1c in this particular survey. And various demographics were noted, including gender, age, rural or urban setting, education, BMI, according to the WHO and Asian cutoffs, family history of diabetes, smoking, and blood pressure, right? It was a large sample all across Pakistan, and the inclusion criteria was that the participant should be 20 years or should be aged 20 years or above. In addition, because the American Diabetes Association has set either the fasting plasma glucose level or the OGTT level as the diagnostic criteria, but because we are using HbA1c here, the authors of the survey did use a subsample to check the sensitivity and the specificity of the H1A1C test, whether it is accurate or not, right? And they compared that with the gold standard, that is OGTT. All right. It was approved by, the survey was actually done by the government of Khyber Pakhtunkhwa with support from the UK. The survey was done from April 2017 to November 2017. And just to show you, okay, so I actually have not included all of the districts that were mentioned in the paper, but they randomly selected districts from all across Pakistan. And the sample size was estimated for the provinces of the country based on the recent census results. And basically, when you calculate the sample size, you look at the expected prevalence, right? So, jo bhi aapne result, whatever result you were expecting, you use that percentage to calculate a sample size, right? Either the variable the outcome that we're looking at is prevalence. So we expect the prevalence, according to the previous studies that were done, to be between 12 to 20%, right? And using this particular data, a sample size of 1,500 subjects per district in each district was calculated, right? And it was proportionally divided between urban and rural areas. And whoever was absent on the day of the survey was excluded from the survey. And whoever refused to participate was marked as a non-responder. Other exclusion criteria included conditions that may affect HbA1c, including anemia. So whoever had a hemoglobin level of less than 120 gram per liters, and this was the criteria in women, and 140 gram per liter in men, they were excluded from the study. Self-reported renal hepatic dysfunction, recent blood transfusion, and use of erythropoietin. These are also some of the things that that were used as the exclusion criteria. Age below 20 years, and as we've already discussed before, refusal to participate. Okay, So the methods that were used to collect our data, so basically it's not just the HbA1c level that we're looking at, right? We were also looking at various demographics. So a face-to-face interview was conducted with each participant to ask them about their age, gender, residential area, their education, family history, and smoking status, right? And this was done in local language, obviously because you're looking at people from all across Pakistan. So you do have to keep that in mind. And then eligible participants were called to a central point and their hemoglobin level was tested. And their blood pressure was also checked. Okay, so coming to the statistical analysis. Now, the differences in the characteristics of the participants were analyzed using the chi-square test. This is one of the simplest tests that you can run. And so association between diabetes and risk factors. So all of the demographics that we noted was sare demographics we checked whether they were associated with diabetes, right? So that is basically a result of that is something that you can check after doing the chi-square test. So the demographics, including age, gender, we've already discussed all of that. These were checked whether the association was significant enough or not. And we also, because we had a subsample as well, right? So the OGTT test that we're not actually conducting, but we basically the authors did select a subsample of participants to conduct that particular test on, okay? So usme se we also to check whether HbA1c was specific or it was sensitive or not, and that was compared to the OGTT test. Statistical significance was defined as p is less than 0.05. Okay, now coming to the results. So we had 22,500 participants. Out of them, 16% were rendered to be anemic and therefore were excluded from the study, right? As we discussed earlier, the exclusion criteria did include anemia, right? Out of those, we were left with 18,856 participants. That is still a very huge number. All of these participants were aged 20 and above, and the response rate was 84%. The median age was 45.23. Most of the participants were men, although this number is 53.55%. So it is, I think we can say that half were men and half were women. 21.96% were hypertensive. Okay. And we did see that 42.55% were overweight according to the WHO cutoff. That is a very large number. And on the central obesity cutoff, 58.04% were overweight and 8.76% were obese. And the mean systolic blood pressure was 126. The diastolic blood pressure was 83. That is pretty normal. 16.98% had type 2 diabetes. And 10.91% of the participants were rendered to be pre-diabetic. So that is what we were trying to look at. What is the prevalence? It is 16.98%. The mean HbA1c level of the entire cohort, so that means all of the participants, not just the ones who had diabetes, but everyone who was tested in this study, the mean HbA1c level for them was 5.62. And among known type 2 diabetes, so people who already had type 2 diabetes, who knew they had type 2 diabetes basically, were 8.68. And the mean value for those who were newly diagnosed in this survey was 8.56. Okay. So this is something that the chi-square test tells you. The prevalence in diabetes differed significantly by age, education, BMI, WC, WHR, family history, and blood pressure. So these are the variables which were significantly associated with diabetes. And the prevalence of diabetes was highest in ages 51 to 60, in people who had no formal education, in people who were rendered to be class 3 obese, and people who had a positive family history of diabetes. And as we'll see in the next few slides, that positive family history for diabetes is very important. There were also significant, statistically significant differences in diabetes prevalence by gender, rural urban area, and smoking status. So people, basically females were significantly seen to, there was a significant association between being female and having diabetes, right? And there was a significant association between living in a rural area and having diabetes. And there was also a significant association between being a smoker and having diabetes, right? So you can say that these were the risk factors. However, on further statistical tests that were run, there was no significant association with smoking in rural urban area. That is also something that should be kept in mind. Out of the all of the participants, there were 1,029 participants who were tested for the 2-hour oral glucose tolerance test in addition to the HbA1c. So this is the subsample that we've been talking about. Taking the oral glucose tolerance test as HbA1c recommended cutoff for diabetes showed sensitivity of 84.7% and specificity of 87.2%. So we can say that it is a pretty good test. Okay, so some of the highlights of the article that we've discussed. As I mentioned earlier, positive family history is very important because the risk of diabetes increased 2.68 times with a prior family history. So if there's someone in your family who does have diabetes, you are unfortunately, the risk of you getting diabetes is 2.86 times more than someone who does not have a family member who has diabetes. So that's also something that should be kept in mind. HbA1c had good sensitivity and specificity, as we've discussed before. The values that we see here, 84.7% and 87.2%, so that is a pretty good test, right? And the advantage that this gives us is the fact that because the OGTT level, it's very time consuming, it's costly. So if you're conducting a community level survey, you can use the HbA1c test instead, right? Because it's easier to do, it takes less time, it will allow you to collect more data, it will allow you to look at more participants in a shorter duration of time, and it will cost a lot less more. And also the previous national prevalence survey that they've mentioned earlier as well, that was conducted in 1999, so a very long time ago, before I was even born. That particular survey did use the OGTT, the oral glucose tolerance test. However, 80% of the subjects were women. So that is not a good study because we need to look at men as well, right? And the reason behind this was because the screening was done during the morning time. So in rural areas where women do not work, they're at home, but men do work and they're not at home. So it wasn't really possible to include them in the screening, right? However, this particular survey, this was conducted throughout the day. Their screening was done throughout the day, so that it was possible for working men to participate in the survey as well. And as we discussed earlier, they constituted half of the study population, actually more than half of the study population. And also the authors comment in the article that the Asian population is known to have a significantly higher risk of developing diabetes. So if you're Asian, you are at a higher risk of developing diabetes, right? And the IDF, this is a very good resource, by the way. They have projections until 2045 right now, I believe, and they have predicted the Asian population to be at a higher risk and also at a higher risk of developing complications as well, right? Obviously, if you have more people developing diabetes, you will have more people who will develop complications as well. The HbA1c test has also been used previously in other community settings, so in the New Zealand as well, and has also been used in Japan. And that particular study that they've talked about in their article, they do reveal that a combination of tests, so for example, if you use a fasting blood glucose and HbA1c together, you will yield more diabetes cases compared with any of these tests alone. So it's better to do 2 tests instead of 1. We've already discussed that it had good sensitivity and good specificity. It is a very simple test. It is less time consuming, so it is ideal for community surveys. And the authors comment that there is no effective primary care in Pakistan. people do not undergo primary screening. So I think like you guys can also relate to this, that even if you have a very positive family history of diabetes, you will probably not undergo screening, or you will probably have not seen your parents or your grandparents undergoing screening unless, until and unless they develop diabetes like this, you start seeing complications. Tab jaake pata chalta hai, oh, this person might be diabetic, right? Or if that particular person goes to the hospital for some other reason, that's when you get to know that this person had diabetes, even if they have a positive family history, right? And so people may present to tertiary care with complications. When that particular person will have complications, that's when you'll get to know that this person had diabetes, right? So we'll also discuss the strengths of this survey. They used HbA1c on all participants, but they did use OGTT on a subsample to check the sensitivity and the specificity of the test. So that kind of validates HbA1c as a screening tool. Also, this was the largest ever survey done in Pakistan, and it was the first community-based national study to use HbA1c as a diagnostic tool. And that is it from my side. I will now hand over the floor to Dr. Hamayle to discuss the findings of this study.
Hello, everyone. That was a great job, Eeman. Are we going to be stopping screen sharing now, or because it's just like it occupies quite a bit of the screen? But okay. Yeah, hi. That was a really well done presentation. I'm so glad to be here with all of you. It's always a pleasure to talk to people from FMH and from my alma mater. And just starting up this journal club, even though this was here before, I remember that we had some sessions before. But this definitely needs to be continued and needs to be fostered, because when you step into spaces like at the Jocelyn, even though like it's a completely different space, but you just realize that we really need to stop relying completely on anecdotal medicine and also really incorporate evidence into our practice. And we can't do that unless we don't have local data. And there is so much to do. I'm guessing a lot of the people over here are like students still and have all the awareness, and they're actually getting inculcated with this environment that they need to start doing research. There is so much that you can collect data on. Start small with FMH. That's just like a general thing that I wanted to talk about. But yes, diabetes is a huge issue in Pakistan. In fact, I just checked the latest percentage from IDF, and it's 26.7% prevalence. And yeah, that's a lot. And I also worked in the endocrinology clinic at FMH before coming here. Not that that's a big sample, but like the types of like it was just like the HbA1cs that we were seeing it was just crazy. Like it was like 12%, 13%. That's a lot. And there's also a lot of like myths associated with diabetes, with sugar, with glucose. Like if we encourage people to do physical exercise, some people would say, "Mujhe gym chad jayenge." And we were like, what? So, like these are also, like there's a lot of barriers to kind of inculcation of a healthy lifestyle and to like abate that sedentary lifestyle that we have. And there was another man that we met. He just started eating naan every day, like one naan every day. And he ended up with diabetes in like 7 months. Like, yeah. And also orange juice. If a lot of, if you people like to consume orange juice a lot, know that that's gonna like kind of lead to diabetes. But anyhow, this was a great paper. Like just this kind of undertaking for it to even be possible in Pakistan, I feel like it's a great effort. And just that the fact that there was this multi-institutional collaboration, that is just amazing. And yeah, the strengths of the paper are like it's a large scale study, 18,000 participants, almost no small feat at all. And I like how they also did the OGTT to check the sensitivity and specificity. However, like the HbA1c, like you mentioned, was taken from capillary blood, and that's not the most reliable. But then again, they had to adapt their methods according to the field that they're in. And given that, I feel like it's an incredible effort, and we need more. Now it's been like 5 years, and of course, it's only gone up. I'm sure it's only gone up. Like there has been I mean, there's no great change, societal change that could ever indicate that it could go low. And diabetes is the complications. Like I myself, my nano, she actually passed away due to diabetes complications. My grandfather, my dada, also passed away due to a diabetes complication. That's also why I feel so passionately about this. But it's so important. Education, I feel like, is very, very important. And for this paper, what I really liked was that they did multivariate logistic regression, and they also did univariate logistic regression. I don't know how statistically aware we all are, but that's a very good model to use, especially when you're seeing multivariate and univariate, which means that you're actually looking at multiple variables and their effect on the outcome. And the outcome over here is basically checking the prevalence. And once you see the interaction between multiple variables, you can really single out, okay, what is causing the most significant effect on the outcome. And obviously, like, as can be surmised, like as can be like predicted, obesity, level of education, all of these are very predictably outcome, variables that do influence the outcome unfavorably. So yeah, the cluster sampling was also excellent. The fact that they were able to like sample all the provinces, it was it's really, really great. And it was also representative sampling because it was multi-stage stratified cluster sampling. Of course, there was exclusion of participants with anemia, which kind of makes sense. But then again, that is a population that we're kind of excluding. But yeah, overall, this article provides valuable insights into the prevalence of type 2 diabetes and prediabetes in Pakistan, and highlights the need for comprehensive strategies for screening, prevention, and treatment of diabetes at a community level. And it also mentioned at the end of the paper that Pakistan is a part of the 2030 Sustainable Development Goals. And the way things are going, we're in 2023. I don't see that happening in 7 years anytime soon. Like it's just mind-boggling. But we just, yeah, so, and even like the graphs are very well presented, like all of it, the tables are really good. I have the physical copy in front of me right now, all highlighted and stuff. But like, yeah, it was really, really, really great. And I hope that there can be a repeat of this or a follow-up of this, because it really contributes to our knowledge of what's going on in the field. And just this really highlights that there is so much you can do in Pakistan, because there's just such dearth of data. Like I said, you can start small, even with FMH. You can see, okay, if there was some way, I know that we have like a digitized, like, because when I was doing house job, like I remember we had all those discharges that we were doing like in the computer system and stuff. But I don't know, yeah, and also the lab values were also in the computer system. But like that is something that can really, that all that data is something that can really be utilized to kind of see patterns within your population at FMH. Like even starting from that, okay, how is, I mean, if the hospital was vested enough, they could literally like analyze lab values of patients in like a prospective cohort and see, okay, how is our performance, how are our people doing, like how are these parameters doing. But yeah, this is really, really great. And yeah, those are I mean, the limitations are definitely there, like we said, like we've already talked about, like you've already presented. But even for this to even happen is really, it's incredible. And it really does give us an idea of the need of the hour, and how big of an issue diabetes is in Pakistan. Yeah, those are my thoughts on that. Do you want to add anything? Sorry, I rambled on for quite a bit.
So I just wanted to say if you could talk a bit more about univariate analysis and multivariate analysis for people who might not know statistics a lot.
Okay. So it's a regression model. So in a regression model, so multivariate and univariate, like this is a little bit advanced stuff, and it really comes into play when you have access to like a statistical software like Stata, like SAS, like SPSS. And I use Stata, but so a regression analysis is basically you're seeing, okay, what is the interaction between our variables and how that influences our outcome, which I already talked about. Like our outcome was basically checking prevalence. And so if we're saying, okay, this is a particular percentage of the population that's going to have diabetes, and we're going to check which variables are associated with that, we're going to look at a regression model. A regression model is essentially a model, like it's very hard to kind of like break it down like that, but a regression model is basically a model that you set that, okay, in like a perfect world, these variables will contribute to the outcome in this specific percentage, and then you compare all of the variables according to that model. So you set a model, and that's something that's like really deep statistical theory and stuff, but that's not something you need to worry about. Like the stata will do it for you. Like statistical softwares will like set a model for you, and then they will compare all the variables according to that model, and they will see, okay, how did obesity influence, how much, like did obesity really have a significant contribution to the prevalence percentage that we're seeing? Like, is that association really significant? So univariate analysis would look at like one variable in isolation and its association with the prevalence. A multivariate analysis will look at multiple variables at the same time and whether they are going to have a significant association with the prevalence of diabetes or our outcome. So yeah, that's like, but yeah.
So basically, in the results, the authors do mention that gender and rural urban area and smoking status was significantly associated with diabetes. However, they do say that upon multivariate regression analysis, they see that there's no significant association with smoking and rural urban areas, right? So what could be the reason behind that? That's what I'm trying to understand.
Well, I mean, I feel like that's a very good question, actually. When the interplay itself and when like smoking itself are looked at like disparately, those will have different influences on that. And smoking is not, I feel like smoking is more for the development of microvascular complications as opposed to just the prevalence of diabetes. Now, if you were looking at like complications of diabetes, I feel like smoking would definitely be a factor because smoking really worsens vascular health. But I feel like that's what they were trying to say, that in isolation, it would not be associated, but as like taken as a whole with the other factors, it would be associated. And I've also seen this in the literature that I've read. Smoking is more associated with the complications of diabetes and not so much the prevalence. Obesity, dietary patterns, sedentary lifestyle, those are much more associated with diabetes than smoking in isolation. But yeah, for like the worsening of complications, that would definitely be right up there. Yeah.
Okay, great. And in your experience, like, could you talk a bit more about, the strategies that we could employ? So, for example, screening and more screening. What are the things that we can do, especially in Pakistan, because we're seeing a huge number of people who have diabetes, right? So, what are some of the things that we should be doing in Pakistan as clinicians working here?
As clinicians, I mean, of course, the intervention needed is much more systemic, I feel, with education level, because over here, and I also feel like I feel like food and nutrition education, can you hear me? I feel like food and nutrition education is very important because our food is naturally not always. I mean, it can be great. हम दालें खा सकते हैं, हम boiled, हम like grilled chicken खा सकते हैं, but अगर हम लोगों ने नहारियां और नान और इस तरह की चीजें ऑयली और समोसे और पकोड़े और फ्राइड और हर वक्त बस ये और बस रोज का बस नान खा लिया और पूड़ियां खा ली और हलवा पूड़ी हर वक्त, तो like it's a lot. So I feel like it's a systemic change, like, and nutrition plays such a big role. Like in the lab I work at, my PI, she's always curious about what people eat. And we're looking at, I mean, Pakistan mein CGMs are not available, so I can't comment on that. But we literally have CGM data, like continuous glucose monitoring data for everybody. So we can see spikes ke unke kis khane ke saath kis waqt kya spike aa rahi thi. And they even put a CGM on me just to see how I would spike. So it's very revelatory. Like I had mozzarella sticks. I had like 3 mozzarella sticks and my glucose shot up to like 200. And I was like, oh my God, I was doing jumping jacks in like the restrooms and stuff just to get my glucose down. But I feel like nutrition is very important, and so is the sedentary lifestyle, and that's something that's very systemic. Us as clinicians can only so much, hum itna hi kar sakte. I mean, people jo grew up eating like, I mean, ek paratha per day could not be that bad depending on the context, but like continuously like mithaiyan or like juices are, by the way, juices are fresh orange juice period jo bhi ho, it's not good. Like it's just the sugar, the glucose out of the fruit literally just taken out without the antioxidants, without the fiber. It's really bad. But like yeah, so I feel like nutrition एक systemic change होने की जरूरत है कि like अब जाओगे road side stalls पे जी चने पक रहे हैं तो इतने तेल में, and it's just so as the clinician at a clinician level, what we can do most is exercise and nutrition advice. I know some family members who literally walked back their HbA1c from 6.5, which is like literally on the brink, and it's like at the cutoff for diabetes, and they took it back just from like dropping all of the regular Pakistani food that we consume and just like going on to, like more vegetables, more plant-based, less oily, less carby, more just like an hour of exercise every day. But then again, and that comes with education. Like if you don't know कि आपके लिए कौन सा food better है, कौन सा नहीं है, then you can't really make those decisions. And sometimes the more that's what's really bad. Like sometimes the most accessible things are the most unhealthy. So I don't think they analyze. I don't know if they, maybe I missed that, but I don't think they analyze socioeconomic status. No, I guess they just talk about area. Yeah, I'm seeing the table too, and I don't think they talked about income. I feel like socioeconomic status also really plays a role, and that's also that we've seen, something that we've seen in papers that I read over here, by socioeconomic status. So yeah, like there were studies on diabetes progression and stuff by geocoding. So they do geocoding, and then that's also, I'm not really like, I haven't really explored that much, but they like stratified in America, like geocoding ke hisab se kaun se zip codes were doing worse, and then they also associated with like socioeconomic status, and that really plays a role. So the interplay between SES, education, and then that informs your decisions about nutrition and physical activity. And unfortunately, I mean, I wish there was a more clinical answer to this, but there really isn't, because diabetes ka nature hi aisa hai. It is a disease that you can very easily inflict on yourself. Chahe aapke genes mein jitna marzi ho, you can stave it off. Like you definitely can if you're just very conscious about your nutrition, about your lifestyle. But those are things who at large hamari population ko, they are not accessible. So it's just, and as for interventions, wo to ek government, jis tarah unhone kaha bhi hua hai that the government said that they would do something, but yeah, that never happens. So I mean, this is something that needs to be systemic. And of course, rural areas mein, aur hamari काफी population jo rural, hamare Lahore, Islamabad, Karachi, bahut छोटी जगह है, मतलब कि कराची बहुत बड़ा है, but like, but those are not really representative of the country. There's a lot more of the population that lives all around Pakistan, और उनके लिए ये सारी like ये हम लोग शायद ना कर पाए. This needs to be like a systemic change. और of course DHQs और THQ में screenings हो सकती हैं, food seminars हो सकती हैं, nutrition advice हो सकती है, like just seminars and in rural areas to talk about nutrition, to talk about food advice, to talk about sedentary lifestyles. Like those are very important. So yeah, that's a very loaded question, and I don't think there's ever a straight answer for a context and a field like Pakistan. And of course it is the need of the hour, but we can't do anything. And of course yahan par log itna delay karte hain going to doctors and stuff, like they just won't go, like jab tak sab kuch pata nahi HbA1c kahan tak pahunch chuka hota, they're like aur phir bas insulin reh gayi hoti hai lagane ke liye, like no, it's a lot. So it really needs a systemic change, and as clinicians you can just like do proactive nutrition advice. FMH की जो endocrinology वाली clinic थी, अब तो मेरे ख्याल में वो खैर समय shift हो गई है. Dr. Atif की specifically, because that's the one I worked in. वहाँ पर they always used to have a nutritionist in like the clinic. So सिर्फ हम तो अपनी तरफ से जो भी कहें खाने के बारे में, but everybody was sent to a nutritionist in the clinic so that they could get like personalized advice and like just told कि आपने किस तरह खाना, किस तरह नहीं खाना. And just like I would call it nutritional illiteracy. Like that's what it really is. Like general से भी ज़्यादा वो एक बहुत ज़्यादा, because लोगों को पता ही नहीं होता कि वो जो खा रहे हैं उनको लगता है बस नान ही तो था, बस 4 आम ही तो थे. I mean, fruit is great, but like अब रोज अब 4-5 आम खाएंगे तो फिर तो it's not gonna work. And we had a patient during my house job who was literally admitted for like 400 glucose, like 400 glucose का level था उसका, और उसको हम लोगों ने इंसुलिन वगैरह लगाई हुई है रात को, एंड हम सुबह आते हैं तो उसका हस्बैंड उसको मीठा पराठा खिला रहा था, एंड वी वर लाइक अब लिटरली हॉस्पिटल इस चीज के दाखिल, so it's just it's like बस the nature of this is such कि आपको वो एक इस तरह की mental counseling and like nutritional counseling करने की बहुत जरूरत है, because उसकी awareness है ही नहीं. But yeah.
So talking about nutrition, my next question was the compliance kis tarah ki hoti hai patients ki, and denial from their side, but I think we've talked about that already. But in my personal experience as well, like I've seen like people who, especially people who are pre-diabetic, like they're in denial ki nahi abhi to kuch bhi nahi hua, so they don't really take the lifestyle modifications that are needed. And also I did get a message if we can ask questions, and yes, sure, you guys can drop your questions in the chat, and if anyone has a question, you guys can also unmute yourselves, just let me know. But yeah, so what is there a difference that you've seen, in patients in Pakistan and from what you've seen or heard in the US? Like, is there a difference in compliance or, like denial from the patient's part?
Okay. Yeah. So we had, well, like I have been in the clinic, but I work particularly in hypoglycemia, not so much hyperglycemia. But हमारे पास CGM का data होता है, so we can always be like, अच्छा इस वक्त spike आई थी, what were you doing at that time? Like, why is there such a big glucose spike? And there was this 97-year-old woman with us, and she said, oh, I like to eat like half a jar of jam every night at midnight. And we were like, what? And then और यहाँ पे लोग बहुत resistant होते हैं. Like my PI, she was like, okay, what if you can just reduce it to like, I don't know, 3 teaspoons, like something, just reduce. Just compliance is like some are in denial. Compliance is a little better though. And like यहाँ पे जैसा my PI very like she once said that people won't walk for themselves, but they'll walk for their dogs. So she's like, okay, get a dog. She's like, you don't have to walk the dog, so you'll just walk for the dog, okay, if you don't walk for yourself. So like but like of course these are completely different populations, and whichever people we're seeing, they've at least done high school, like at the very least. Or Boston में जो trickle down होके आते हैं वो तो फिर बहुत ही, like they're usually like have higher education degrees, so they're very cognizant of what is happening. It's usually the elder population that is very set in their ways, and they're like, acha, we can't change, like just I have to have my jam at midnight, I don't care what you say. But like the younger population is much more receptive to feedback, and yeah, and they also don't have like spiritual myths sort of associated with like literally I still can't get it out of my mind. Just बंदी ने कहा कि मैं walk करूंगी तो मुझे जाके दिन चमड़ जाएगा. I'm like, what do we even say to that? Like हम क्या मतलब so like of course एक वो education level की बात है. Of course आप जिस society में हो फिर उससे definitely फर्क पड़ता है. I mean it is what it is. Like you those things just can't be changed. Like वो barriers like हैं, those are prevalent and they're going to stay. So I would say compliance is slightly better. Denial भी है, but it's slightly better. But हाँ वहाँ पर तो like उन लोगों को तो पता होगा कि हम भी बुरी चीज खा रहे हैं or something. लेकिन पाकिस्तान में तो मसला है कि उनको पता भी नहीं कि वो जो खा रहे हैं वो बुरा है. That's the problem. और हमारी जो मिठाइयाँ हैं, they're like soaked in शीरा और पता नहीं क्या. But another one thing that I would note is that in America, grocery, everything has added sugar. Everything has added sugar, even savory stuff has added sugar. It's crazy. Like मैं granola देखूं, oatmeal तो वैसे ही, if any of you are, I mean Pakistani oatmeal, if any of you are like really into oatmeal is not that great for blood glucose. You should just know oatmeal is touted as that really great nutritional food, but it's not that great for blood glucose. It causes quite a spike actually. But America में मसला ये है कि Americans unknowingly consume a lot of sugar because they feel like वो तो कुछ savory खा रहे हैं, कुछ बस yogurt खा रहे हैं. But it has so much sugar, like a random yogurt bowl over here would have like 22 grams of added sugar, and the highest you can hit with added sugar is like 65 grams. That's the max. You shouldn't even be hitting that much. Like, added sugar honi nahi chahiye वैसे भी. But like यहाँ पर you have to, like myself, I have to be very careful when I'm shopping for grocery, because you really have to look at कि किस चीज में क्या कितनी added sugar है. It's a lot. Like it's a lot. And then there also एक और चीज, there's actually the study called the masala study. Funnily enough, it's called the masala study. So it actually looks at mediators of atherosclerosis in South Asian populations in America. You can look it up, like it's by the UCSF. And even though it's looking at atherosclerosis, but they identify type 2 diabetes as a big factor for developing atherosclerosis in South Asian populations. And one striking, they had like a seminar at the Jocelyn, and one striking finding that they represented was that at the same BMI, a Caucasian person and a South Asian person will have completely different percentages of body fat. Like body fat at the same BMI of a white raised person and like a South Asian person, we will have much more body fat than Caucasian people, because we're just genetically prone to developing metabolic disease. And it just blew our minds, because we could have the same BMI, but we could have completely different metabolic makeup and metabolic, how we're looking at, like, like how our fat percentages are, body mass percentage, like it's absolutely crazy. So we have to really work around our genes and what we've got. And ये अब इस तरह की ये epigenetic changes अब ये एक generation में तो नहीं आती ना, like it's gonna take a long time for it to actually tilt toward like a healthy pattern. But yeah.
Alright, so one of the participants has a question, Nurul, and you can unmute yourself if you want to. Or you can send it in chat too, it's fine, whatever you're comfortable with. And also, one thing that I wanted to comment on, you mentioned that the compliance is better in the younger age group, right? But also, like, we do see a lot more prevalence in the older age group. So I think that is also unfortunate.
Yeah. Okay, so Nurulan says diabetes is treatable, right? If a person is taking all the precautions, is it curable as well? Also, if he's taking insulin or metformin, is it said that he's going to survive not more than 15 years? Okay, I don't know where you're getting that figure from, but like like that figure can, like 15 years cannot really be like a set thing. It really depends on a lot of things, HbA1c, current glucose control, complications. Like it's a lot. Like diabetes is an ever evolving prognosis. Like it's not one ke, oh yaar, itna HbA1c aa gaya to bas 15 saal mein khatam. That's not going to happen. Diabetes is treatable. Okay. So if we're looking at type 2 diabetes, that is obesity induced, and that's treatable or in remission by metabolic surgery. By metabolic surgery, I mean bariatric surgery. And just lab में मैं काम करती हूँ, उन्होंने actually देखा भी है कि bariatric surgery versus medicinal treatment, and bariatric surgery, like diabetes is not curable, it is remissible. Like वो आप remission में लेके जा सकते हैं, आपका HbA1c फौरन नीचे आ सकता है अगर वो obesity induced है. So after bariatric surgery, all of the people were quote unquote cured of diabetes. And metformin and insulin, these are for management. These are not curing the problem. आप जब pre-diabetes की stage में हैं, तो आप, you can definitely walk it back. You can implement dietary intervention and active lifestyle. But curable as such, I won't say that. No, it's more of a management. And curable, the closest to curable somebody can get with type 2 diabetes, obesity induced, in fact, is through metabolic surgery, or उससे फिर remission रहती है. Because and like diabetes is very closely linked to adipose tissue. Another thing that the lab investigates. Adipose tissue is like the more BMI, the more adipose tissue, it's definitely going to induce diabetes. Yeah, so that's my answer to that. What's the best diet for a diabetic patient? Can you share any plan from morning to night? You should visit the American Diabetes Association's website. They have excellent resources. They have meal plans. They have recipes. They have non-starchy. In fact, I have something on my own desktop that I can put in the chat because I'm very interested in this myself. And this is also sort of like a thing that I try to incorporate when I go grocery shopping. Wait, let me see. But non-starchy vegetables. Wait. Yeah, wait, I can't find it right now. Sorry about that. But so you should go to the ADA website, American Diabetes Association website. उस पे सारा कुछ लिखा होता है कि कौन सी vegetables non-starchy हैं, कौन सी lean proteins हैं, कौन से are healthy sources of fat. Those are definitely fiber intake, plant-based diet intake, all very important. Yeah, like my own parents, actually they're the ones who kind of like walk back diabetes. And Dr. Atif often कहते हैं कि मैं उनकी तस्वीर frame करके अपने ऑफिस में लगाना चाहता हूँ क्योंकि पहले पाकिस्तानी कपल है जिन्होंने diabetes walk back किया है. So I'll just tell you what my parents do. Like they have fiber, they have like, wait, is there more? Yeah, okay. They have quinoa, they have fiber, they have मतलब कि उन्होंने carbs काफी, I mean elimination तो नहीं करनी चाहिए carbs की, a small portion, but the predominant portion of the plate should be greens and lean protein, fish, chicken, less fatty meats of less fatty cuts of meat like beef. Eggs are an excellent source of protein. Or subah, and to set yourself up for success, don't go for sweet breakfast in the morning. That's just setting yourself up for failure. Like subah, and cereal is a scam. Cereal is a scam. It has so much sugar and it's nutritionally so deficient. No protein. Remember this. You have to prioritize protein in your diet to be able to stave off anything, be it diabetes, be it sweet cravings, because protein is a satisfaction factor of your diet. हाँ, protein को आप बहुत ज़्यादा तेल में तलेंगे और उसको उस तरह खाएंगे तो वो तो अच्छी बात नहीं है. लेकिन boiled eggs वैसे भी कम तेल, chicken, lean cuts of meat, poultry, fish is really excellent. Then there's also plant-based sources, लेकिन वो पाकिस्तान में कोई इतने accessible नहीं है. Like I mean edamame और ये बहुत fashionable चीजें हैं पाकिस्तान में. I would never recommend anybody to. तो you know like, और दालें भी अच्छी हैं, but दालों के अंदर भी carb content होता है. Amazingly enough, उनके अंदर भी काफी substantial carb content होता है, but उनके protein content भी होता है. okay, my father is non-diabetic, he takes cereal daily because he thinks it can prevent it. No, I don't agree with that at all. You should look at the nutritional label. हाँ अगर वाकई कोई added sugar नहीं है, but I would just say cereal is a crap breakfast overall. Like आप कोई protein खाएं. हाँ cereal you can have as a treat, थोड़ा सा like a sweet treat after you have your main breakfast. I would always say कि a protein focused breakfast is the best. Okay, what about someone who needs about 2,600 calories a day for maintenance, is living alone, has a low appetite and wants to gain weight? It's literally impossible to eat clean. Are you exercising? You will want to eat if you're exercising. Are you working out? Are you doing strength training? यार पाकिस्तान में हो, मैं यहाँ पर आके मेरा जिम छूट गया, मुझे इतना रोना आता है रोज. I was strength training in Pakistan, बहुत भूख लगती थी. Strength train करो यार, मतलब you know. अच्छा. Yeah, okay, that's great. ऐसे न आपको you're not feeling hungry despite that. Like फिर तो ये पूरा this sounds like a workup, but low appetite, wants to gain weight. You could start looking into protein shakes, even though I won't suggest going ham on that either. You could start looking into for bulking. फिर तो वो gym bro style lifestyle आपको फिर जीना चाहिए. No, I'm just kidding. I'm talking in a very casual way because आप लोग सारे मेरे juniors हो या फिर जो you know like आप FMH से हो, तो मैं इस तरह ही बात करती हूँ. Hair, it has a low appetite. Okay, that would need to be investigated if you have like a low appetite. This is not something, this is very small, like आप पूरी complete history के है फिर इस तरह advice नहीं दे सकते. But like generally I would say कि strength training ज़्यादा करें, cardio भी incorporate करें. If you're not, every meal plan for bulking is full of sugars, then you cut out the sugars. Like you modify the meal plans then. You know, just start eating lean protein. अगर meal plan को to a T follow करने की ज़रूरत नहीं है ना, then you need to modify the meal plan. Could historical droughts, famine during British rule? Oh, absolutely. Yeah. That is very true, Saad. That is one of the that is definitely a dominant epigenetic factor that has kind of put us into that. In fact, हमारी bodies like हमेशा starvation के लिए तैयार होती हैं. They're like अभी उनके our genes have been taught कभी भी खत्म हो जाएगा खाना. So our bodies want to store fat. They want to hold on. Definitely, epigenetic factors have a lot to do with it. Saad, thank you for that comment. So yeah, SN, you need to modify your meal plans. You need to also incorporate some cardio, or you need to switch up your routine for exercise if you're not feeling hungry. And you might also want to have like a good metabolic workup, and that by that I mean get your blood levels go to. I mean, like if you feel like your low appetite is really a big problem, I would suggest you go for a workup definitely. But yeah, modifying your meal plans, modifying your exercise, and getting good sleep, very important. Sleep, low sleep, high cortisol, stress response, hyperglycemia. Straight as that. Okay, any other questions? I'm sorry, I went very, very like casual towards the end. Also, anybody, if you can reach out to me anytime on Twitter, I'll just type out my, oddly enough, my Twitter username is Hamayle, even though I have like zero interest in hematology oncology. It just sounded nice. But yeah. Yeah.
Okay, so since it is 9 p.m., if we do not have any further questions, we will be closing for now. Thank you so much for joining us today, Dr. Hamayle. I know that you are a very busy person, and so I am grateful for you to, okay, thank you for that, Ahsan. I am grateful for you for taking out the time to to join us today. And hopefully we'll have more sessions with you in the future, and hopefully we'll continue the journal club throughout the year. And yeah, that is it for today. Thank you all for tuning in, and Allah Hafiz.
Allah Hafiz. Thank you so much, you guys. Thank you for being a great audience. Bye.